As you know, our keynote speaker today is Dr. Bhavnani, but due to his time conflicts, um, he will be able to present now. So I will go with your brief intro, Dr. Bhavnani, and you can start sharing your screen with the presentation.
Can you see my screen?
Yes, I can see your screen. Yeah.
Okay, great. Excellent.
So Dr. Bhavnani is a professor of biomedical informatics in the Department of Biostatistics and Data Science at the University of Texas Medical Branch, senior fellow at the Seeley Center on Aging, member of the Institute for Translational Sciences, and adjunct faculty at the School of Biomedical Informatics in UT Houston. Dr. Bhavnani obtained a Ph.D. in computational design and human-computer interaction from Carnegie Mellon University and specializes in network visualization and analysis of biomedical data with translation to the design of decision support systems. As a director of the Discovery and Innovation through Visual Analytics Lab at UTMB, his research has received 5 distinguished paper awards in biomedical informatics from the American Medical Informatics Association and is PI on the grants from NIH, CDC, and PCORI. So welcome, Dr. Bhavnani, and you can start sharing your presentation, and the title looks really impressive. Yeah.
Thank you so much, Dr. Gupta. It's such a pleasure to present this work. This is hot off the press. It's work that we've been doing in the last 3 months, from AI to advocacy, my reluctant journey into policy translation. As Dr. Gupta said, my background is in computer science. So what the heck am I doing trying to translate into policy? That's the journey that I'm going to be talking about. This research is funded in part by the UTMB CTSA and a recent grant from the AIM Ahead. So everyone cares about fairness: patients, clinicians, researchers, and funders. In fact, 2 weeks ago, when I attended the AMIA summits, there was a large number of sessions and panels just on fairness. But the question is whether the healthcare policies are fair. How fair are federal and state healthcare policies? That's the question that I wondered about, but I don't have any background in that arena. Let's take an example of the National Alzheimer's Policy Act, called NAPA, that was passed by the federal government in 2021. In Section 6E of this policy, it states that Black, Hispanic, and low-income populations face a higher risk of AD and ADRD, this is Alzheimer's disease and related dementia. This requires that addressing SDOH, which stands for social determinants of health, entrenched systemic racism and other forms of discrimination be prioritized rather than focusing solely on individual behaviors. So you can see that this policy targets or divides Americans based on race, ethnicity, and income. So these are essentially demographic variables. So the question that I asked are such policies that divide people based on a few demographic variables like race and income, are these really fair? It appeared to me that this was a too simplistic way to divide Americans, given the large heterogeneity among those categories. I just felt that it was time to readdress such disparity policies, perhaps in a new way using AI. So because I don't have any background in politics or in policy making, I wanted to share with you what I learned in the last 3 months as I have started my journey in the process of translating AI research into policy making. This journey consists of three parts. The first is the standard AI machine learning approach, where I will talk about the social determinants of health, which are defined as the non-medical factors that influence health outcomes. And research has shown time and again that it accounts for between 30 to 55% of health outcomes. However, several models in the past have clearly stated that Americans face combinations of SDOH, right? So a lot of the research has focused on single social determinants of health, such as transportation, delayed medical care, etc., and how those variables are associated with outcomes. But these models are talking about how they co-occur. So the first question that I asked was, how do SDOH co-occur to form SDOH subtypes? So this, I won't spend too much time on this because this is the standard AI. Then I begin my journey in terms of the implications of these subtypes to healthcare policy. I quickly realized that policymaking is complex and way outside my expertise, outside my comfort zone. And most of the discussions that I heard with my colleagues or at the CTSA level was about funding for foundations. Whereas, I was interested in how can these SDOH subtypes actually be translated into healthcare policy. Now, over the last 10 years, my research papers have always ended with, these are the AI results, and future research will explore how these can be translated into clinical care or in terms of healthcare policy. So I always ended with implications, with a few sentences in the discussion section, and then moved on to my next AI project. But here, I will describe to you how I took the results of my AI research and started a serious discussion with healthcare policy experts. So that's the second step in my journey. But then going forward, how do these implications based on the healthcare policies can they be actually translated into federal law, right? I have no experience in that, and I've begun that experience. So translating a policy proposal from research into a policy brief, which is the document that is shared with Congress, with legislators in the Congress, who then debate it on the Capitol floor to get votes to transform it into a law. This whole process is fairly complex. I have no background about this. I always assumed that someone else would do this for me, but over the last 10 years, I have gradually realized that the only person that can do it properly is me, because I know these methods. I know what they actually mean from a data point of view, from an algorithm point of view, whereas the policy folks don't know that. And so the handshake has to occur. And so the third question that we're in the process of exploring is how to design a policy brief. This is the 2-page document that can be presented to legislators. So in the first question, very quickly, we asked the question, how do SDOH co-occur to form SDOH subtypes? Many of you know the All of Us data set has a massive collection of participants, which is growing. Their target is 1 million participants. At the time that we extracted these data, the number of participants was up to 372,397 participants. We extracted all of them. We identified 110 SDOH self-reported variables. These were collected from 4 surveys through consensus by 3 SDOH experts that went through all of these questions that were related to SDOH. Then we did the standard machine learning, data science approach where we had to clean up the data. We negatively coded all the variables so that they could be used in the machine learning algorithm. We dichotomized the variables, excluded invalid responses, abbreviated the questions to shorter labels so they could be interpretable by the domain experts. And finally, we handled missingness and bias using a method called inverse probability weighting, because the missingness was not random. And working closely with biostatisticians, we use inverse probability weighting to handle the imbalance in demographics once we dropped particular patients. So now we were ready to proceed with the analysis. The method that we use to identify the SDOH subtypes is a method that I've been working on called bipartite network analysis. Now, most of you know that unipartite networks consist of nodes and edges. This comes from graph theory. And this is typically used in social network analysis, SNA. So this is extremely well known. The problem is that if we use this representation to model the similarity between patients, this edge here would have to be some aggregation of all the SDOH, right? So you would have to use measures like Jacquard or correlation, Euclidean distance, all kinds of measures. Unfortunately, when you collapse a whole bunch of variables into a single number, that aggregation becomes a black box and very difficult to interpret as to why exactly patient 1 is similar to patient 2, as shown in this diagram. So we opted to use another representation from graph theory called a bipartite network. And a bipartite network captures both sides of your data, the patients, which could be your rows, and the characteristics of those patients. This could be genes, this could be SDOH, this could be comorbidities, symptoms, whatever you want, right? So this is a very general representation called a bipartite network. And now the edge here describes whether this patient has this particular characteristic and immediately opens up the black box for interpretability. This has very powerful implications. This shift from a unipartite network to a bipartite network has important implications because it automates how the biclusters are identified. So unlike other methods where you have to guess the number of clusters, you use modularity maximization, which is a machine learning method, to automatically partition the data into biclusters. So here, each of these circles, just like this, represents patients. The triangles represent the SDOH barriers, and the lines or the edges that connect participants to their variables is the IPW weights to deal with the bias in the data, right? This modularity maximization approach gives you a number that describes the quality of the separation, which describes how strong the clustering is. We can use that number to compare it to a distribution of randomly permuted data sets to measure the significance. And next, we can measure the risk of each of these biclusters using regression to calculate odds ratio. So over the last few years, we have completely automated this process. You take in the data, you press a button, and out comes this visualization with the odds ratio. So the quantitative analysis is automatic. But the most important aspect of this presentation today is the visualization. Graph theory offers you a bipartite visualization graph such as this, where the nodes can be colored based on the outcomes. And this then can become the representation that domain experts look at. And if you're looking at molecular data, they can infer the biological pathways. If you're looking at SDOH, they can infer very clearly the potential mechanisms that lead to outcomes such as depression. So we have experimented with this representation for several years, and that's what we used in this project. The results were as shown in the training data set, which had 6,492 participants that had complete data of those 110 SDOH variables. The significance of the modularity was quite high, and then we replicated it in the test data set in terms of the co-occurrence of these SDOH variables. The results automatically generated 4 biclusters. So for example, cluster 1 represented was inferred by the domain experts as socioeconomic barriers. And those SDOH were low educational attainment, low literacy, low income, etc. And on the other end is cluster 4, which deals with sociocultural barriers. These labels were given by the domain experts after they looked at this diagram and they looked at these labels. And these sociocultural barriers were like language barriers, disadvantaged neighborhood characteristics, etc. Right? So the bipartite network representation, where each of these dots represent participants from all of us. The triangles represent the SDOH factors. These are the labels of those SDOH factors. This representation was very interpretable by the domain experts, and they could understand that. Next, we did the risk assessment for each of these biclusters. And we tested the risk for depression, delayed medical care, and ER visits in the last year. These are 3 important outcomes strongly related with SDOH barriers. And the paper describes in more detail the results, but overall, the main pattern was that cluster 1, which related to socioeconomic barriers, had a significantly higher odds ratio for all 3 outcomes when compared to cluster 4. And the interpretation of this, the mechanisms that lead to that difference in risk for each of these 3 outcomes, is that if you're an American, let's say you're 45 years old and you have low educational attainment, low literacy, low income, you feel stuck in your social mobility. It's very difficult for you to get out. You experience stress in your life because you're trying to make rent, etc. And you don't have the resources or the motivation to get additional education, and that leads to chronic depression. On the other hand, if you had these barriers from a social determinants of health point of view, these are relatively modifiable. If you have a language barrier with your provider, it could lead to, you could get a different provider. If you lived in a disadvantaged neighborhood which has violence, perhaps you could address it. But even if you cannot address it, you can perceive these SDOH as being relatively modifiable compared to these where you're stuck. So that, in summary, were the results from the machine learning approach that we took to identify how the SDOH barriers co-occurred in a very large data set. The next question was, what are the implications of those 4 SDOH subtypes on healthcare policy? So we did a qualitative case study. We assembled 3 policy experts from a leading public policy institute and think tank. This panel had expertise in analyzing, designing, and advocating healthcare policies targeted to state and federal agencies. This is the background, obviously, as a computer scientist, I don't have at all. And they had different backgrounds, which range from medicine to political science. So they were these three policy experts that I solicited the interpretation and the implication of these SDOH subtypes for healthcare policy. We had a total of 10 meetings. Each member of the panel studied the evidence that I just showed you of the SDOH subtypes, provided recommendations for the translation of those SDOH subtypes into policies, not into medical care, but into policies, healthcare policies. And then we had a final meeting for group consensus. This is currently an abstract. This is under review. The results are quite interesting. Expert one, and I'll read, said he agreed that we could start exploring replacing current disparity policies that are based on a few demographic variables like race and income with need-based policies, right? So currently it's about demographics, which is too, in my view and his view, simplistic. But we have now AI methods that could potentially shift the partitioning of Americans based on need instead of just on a few demographic variables. And this need-based policies could be done, as I demonstrated, using the co-occurrence of SDOH barriers. This shift could lead to more efficient and equitable distribution of resources. So this was a confirmation of some of my initial ideas. However, expert two had a different take. She said that race and racism cannot be ignored. And there will be a very great pushback from advocates of race-based policies. In addition to SDOH subtypes, she recommended to identify which races are significantly higher in specific SDOH subtypes and design targeted policies that are culturally sensitive. So this was a brilliant stroke of advocacy that she introduced, because she is introducing the variable of politics. Anytime you divide Americans, there is going to be a battle. And in that battle, which is very well known in the political field, you need to be able to answer specific questions and address different points of view. That's what expert two is saying. She says, yes, you can move towards a need-based policies, but don't forget that racism is a real problem, and therefore address it by doing enrichment analysis of these subtypes and then designing your policies that are culturally sensitive. This was brilliant, how she is introducing policy into the rationality of translating the results into policy. Expert three came roaring in, and she said, wait a minute, there's something more interesting going on here. CMS plans to collect SDOH variables nationwide, resulting in subtypes that could vary across geographic regions. Therefore, instead of one set of nationwide subtypes, propose a method instead to analyze the SDOH co-occurrence per county with policies customized per county. This was amazing, right? Because in the US Constitution is the whole concept of federalism. And federalism essentially defines laws at the federal level, which are very broad, and but gives powers to individual states to interpret them so that you deal with the heterogeneity across America, right? And that's what she's talking about. She's saying, don't forget that your SDOH subtypes that you've identified, yes, it's at the national level, but it may not be relevant when you go down to the state or the county level. And why are you pushing one set of subtypes to everyone? Use the whole process of federalism, take the data from CMS, and then the policy that you propose should be based on the method, not the subtypes. So you can see how politics and the Constitution is being integrated into the AI results. So the consensus from this study was that instead of proposing SDOH subtypes, we should propose a method to automatically identify SDOH subtypes, determine their risk for adverse outcomes, and the racial and ethnic composition of each SDOH subtypes. The visualization of the results could be used to explain how these resources will be allocated. But more interestingly, was the feedback they had on the method. So they basically said that the bipartite representation was powerful in their view because unlike k-means and hierarchical clustering, this was completely agnostic of any input from the machine learning expert, right? Because they were automatic. The number of clusters is done automatically. So the automatic boundary identification of subtypes can speed up analysis of large county level data sets in real time, right? Because if you're going to do every county in the US, this method should be easy to use and automated. So the bipartite representation also provides strong boundary and risk interpretations by the policy analysts, right? So that was it. Expert 2 came in and basically said that in politics, anytime you divide Americans, those boundaries are actually fuzzy in nature. And that's what your representation is showing, right? So unlike unipartite clustering methods, the bipartite clustering method shows you how participants in one cluster share SDOH variables in other clusters. And this is known as boundary tensions, which is very important in the discussions when you're dealing with stakeholder debates on boundaries. Expert 3 then said that this visualization becomes very important for those debates on boundaries. So you put people together at the policy analysts or other experts at the county level. This representation then can become very powerful for them to have their discussions because ultimately politics is about compromise about the intended and based on the intended and unintended consequences of dividing Americans into these different stratifications. But then expert 3 said this representation could be good for policy analysts, but is probably not good for a congressman, right? It's too complicated a representation for someone, that doesn't have a background either in policy analysis or in machine learning. So they recommended to start exploring much simpler representations such as a Venn diagram, like I've shown here, which would be in the policy brief. We're still exploring different representations, but this was a very important point because we really want to be able to make the results understandable by the legislators. So in the consensus across these 3 experts, these were their individual feedback on the method. The consensus was that this method, the bipartite graph representation, computational, as well as the visualization, had 4 important properties from a political point of view. They helped to automatically identify the boundary, the boundary identification. It represented the boundary tension. It enabled those kinds of discussions. It could serve as a boundary object, which is a sociological concept of how people find common ground. And finally, specifically for a policy brief, you needed a simpler approach than the bipartite representation. So once again, the bipartite was good for the policy analyst. It was not good for the legislator who had to debate it in Congress. So now the final question is, well, that's good. We've learned a lot from the policy analysts and the political scientists. How can we convert it into a policy brief? And this is our ongoing research, which is an iterative process. The format has to be a 2-page policy brief written at the college undergraduate level because the congressional staff members are the gatekeepers, and they have bachelor's degrees in political science. So it has to be written at this level. The content must have a compelling case because it has to excite the congressional staff members, who then would take it because they have hundreds of all these policy briefs coming in. Which one do they pick to share with their legislators? We also will be the currency in politics is votes. And so we have to build interest groups by building a coalition with other interest groups and get signatures to show that there is community support for our approach. And then we're also using similar approaches to target legislators. So that's question 3. So in conclusion, I started this research assuming that these subtypes used that were identified through our machine learning methods would be the policy, right? That's what I was initially proposing. And I ensured that the data and the AI algorithms were fair. I did all the good stuff. But what I learned, right, from this journey into policymaking is that it was not the subtypes themselves, but the AI method that could be used per county level, embracing the notion of federalism in the US Constitution. This would address the geographic and temporal changes in SDOH, so you're not fixed with one set of SDOH, and it would also address the interpretability, which is very important in politics, so that different constituents would debate the boundaries that are being proposed per county level. So interpretable AI with specific properties can be used for implementing fair policies. This is just one example, and we have just started that journey. So in our current and future research in the Aim Ahead project, we are extending this whole approach to what we're calling the AI Policy Nexus Framework to ensure that our research gets translated into high-impact policies at the federal and state level. So we describe these 2 steps. We'll also be building classifiers and prediction models, and all of these will be examinable and interpretable by human experts, including policy analysts. And right now, our framework essentially says that these representations should enable boundary identification, should enable the discussion of boundary tensions. Anytime you divide Americans, there's going to be tensions of who gets what. And so that has to be part of the discourse. It should function as a boundary object to enable people with different diverse backgrounds to be able to discuss these boundary tensions. And finally, the actual results should be easily communicable to legislators and not just the policy analysts. Thank you very much for your attention, and I would love to take questions.
Thank you very much, Dr. Bhavnani, for the wonderful presentation. And it's really interesting. I can say it's a good example of translating the computational methods into a real world application, and which is more interpretable and like understandable by the non-technical users, usually if you translating something to a policy. So we just running out of time, but I just have a short question.
Yes.
Basically, when you are applying these clustering methods, I know
Yes.
like you are using a large amounts of data and there are a lot of variables involved, and you get that visualization, which is very interpretable, right, at the end. So will that be like too much time consuming when you are building that, like to get into that visualization at the end, or like it was kind of like efficient manner of putting that? I assume that it will take more time to basically train and come up with that outcome.
Actually, no, that's an excellent question. For the 6,000 patients, it was under a minute to come up with
Oh,
the
wow.
with the entire pipeline. The part that's time consuming, which grows exponentially with the number of nodes in the network, is the estimation of the significance, right? Because we take the same data, we permute it 1,000 times to generate 1,000 null models, right? And we run the modularity algorithm 1,000 times. So those 1,000 times, that's where the cost goes very high. And so for this particular data set, it took about a week on the All of Us website or the workbench to run that, right? But then after it was done, it was over. But so the visualization itself, the analysis itself, no problem. But if you want to publish the results, then you have to do the computationally expensive significance, which most people who do clustering, they completely ignore. But we made sure that for biostatisticians, in the biomedical field, to make sure that the clustering is significant, right, before we move on. But yes, the significant step is the costly step, but not the original visualization.
Okay, wonderful. We do have just one more minute to take another question, and then we start the panel discussion. I think we got something on chat. Has this research being published?
Yes. So the machine learning results is on medRxiv. It's been accepted by JMIR, and it's in its final formatting state, but it's already on PubMed. The code for our methods are on CRAN. I can send people that link. And the code also is on the All of Us workbench for public use. There is a link in the paper to get access to that. And the research related to the translation to policy, that's under review currently. And we're working on a journal version of that also.
Okay. Great. So I think we can